Welcome to Clinic Pasteur for this recorded case of a transfemoral TAVI with the Portico device. So my name is Didier Cheche. Nicolas Dumontel, so my friend and partner, highly experienced with the device, and Sabine, who's going to help us, the nurse who is going to help us today for the procedure, and Marlene is going to be the circulating nurse. So, Nico, without further ado, should we start with the case presentation?
Yes, thanks, Didier. So the patient we're going to treat today is an 88 years old female, having, of course, severe aortic stenosis, not overweighted, as you see, suffering from hypertension and non-insulin-dependent diabetes mellitus. And she experienced recently a pulmonary edema that revealed the progression of this aortic stenosis to a severe status. And despite optimization by medical therapy, she's still symptomatic in shortness of breath class 2 and effort angina. On the baseline ECG, she's on sinus rhythm with a right bundle branch block. On laboratory investigation, nothing remarkable. The transthoracic echo showed a normal left ventricular ejection fraction. Of course, severe aortic stenosis, 0.9 centimeters square, mean gradient 54, and no pulmonary hypertension at rest. On the baseline angiography and probably partly participating to the angina is a severe stenosis of a mid-LAD at a bifurcation location with a big diagonal branch, a Medina 010 bifurcation lesion. On the CT scan, we see at the annulus level a perimeter-derived diameter at 20.4, almost comparable at the LVOT level, 21 millimeters, so a tubular configuration. The SOV is a generous 32, takeoff of left main and right coronary artery, also comfortable in this sinusal valsalva, so no issues regarding coronary perfusion in case of TAVI. The projections we could use in the cusp overlap view is an aerial 11 caudal 20, and you see on the right an overall view of artery as iliofemoral arteries and aorta, but are really favorable for TAVI transfemoral. So these are the risk scores, and this patient, of course, was assessed by our heart team. And considering all the factors that you saw, was offered a transfemoral TAVI solution. Next slide. So our strategy today that you will see on the next slide is a routine streamlined transfemoral TAVI under conscious sedation, all the setting conventional that you'll detail Didier. We'll predilate with a 20 millimeter balloon, intend to implant a Portico valve with a commissural alignment technique in order to preserve coronary access and perfusion. And based on the severity of the coronary lesion and its symptoms as angina that this patient is experiencing, we'll perform a PCI on this LAD lesion.
Perfect. Thank you, Nico. So the valve is going to be a Portico 25. So, Nico, we have that projection that was proposed by the CT scan.
Yeah. And I think we have live confirmation that the predicted cusp overlap view is quite good, and the one we'll use to improve and make the positioning more accurate regarding the issue of potential AV block. And it's why it's the most useful and to use this cusp overlap view. And we'll detail while implanting the valve how to interpret this projection also regarding the commissural alignment technique. Okay, so in hemodynamic, you see we keep in mind for the final hemodynamic assessment the level of LV and diastolic pressure, that is 20, aortic diastolic, that is around 40. And heart rate at 62, 65. So let's keep that in mind.
We have a very high gradient. It's,
of course.
More than 60. What is really interesting, Nico, is once again the location of the left ventricular wire that is not pointing towards the non-coronary cusp between the non and the right. And that tells us that for a need of pre-dilatation because we have some bias. So we're going to pace at 180. Okay, pacing on. Okay, you can inflate, Nico.
Balloon up.
Balloon up. Injection. And deflation.
Balloon down.
And pacing off. Okay, so let's just withdraw the balloon and then we will review what we have, Nico.
Yeah. We immediately see that we don't have a 3rd-degree heavy block. And sometimes with such baseline RBB, it happens just after the balloon valvuloplasty. So it's not here the case.
So that's a very important comment.
Yeah, pressure recovery is good. So we always, in such situation, perform the BAV having the valve already prepared to be implanted in case of hemodynamic crush. So let's review the BAV. Yeah.
So what we see is first quite stable position of the balloon. We don't have any major filling of the LV, so the 20 millimeter really matches the mean perimeter derived diameter of the annulus. So we should be okay with a 25. And quite importantly, we know that the left coronary takeoff is quite high, but here there is no obstruction despite the calcium load at the level of the leaflets that we can clearly see here. For the right, we don't clearly see it because there is a bias of the balloon towards the right part of the anatomy that explains that aspect.
Okay, so let's go for valve implantation.
Okay, Nico, so the capsule of the catheter is within the right common femoral artery. We can see the integrated sheath. So do you want to drive us towards the way you rotate the handle to be sure that we have a proper commissural alignment?
Yes, so we'll see inside the patient you have also some landmarks in the frame to follow in order to achieve this commissural alignment. But the way the valve is crimped into the catheter allows you to predict this possible commissural alignment by orientating the delivery catheter in a certain way. So you see this side flush port that is here, and you just have to orient it towards 6 o'clock. So like that, you turn clockwise, quarter turn. It's now facing down to 6 o'clock, and that way we have a high likelihood to have a good commissural alignment.
Okay, very clear. So let's advance and see how this catheter performs within the anatomy. The FlexNav is really a superb delivery system that is highly flexible and definitely to track through the tortuous vessels, it's not an issue. So we may come back to our working projection. It was RAO 10, caudal 20. So for once, it's not a too extreme projection. And what we can see already is that the commissural alignment is almost is really nice.
Yeah.
I'm going to record without contrast. And now you can see that one of the posts that is pointing towards the utmost anterior aspect of the anatomy, towards the right part of the screen, is seen perpendicularly like a straight line, whereas the other ones are a little bit thicker.
Yeah.
So we could rotate a little bit more, but already that commissural alignment is nice for this patient.
So maybe to re-emphasize on that, Didier, because it's not something maybe our colleagues are used to looking at. What you have to look at now is not the bottom of a prosthesis, as we usually do for positioning, but just the mid part of a frame that is inside the catheter, where you see 3 posts. Yeah, you have them currently under your eyes. And if you when you work in a cusp overlap view as we are, if you look at the right part of a frame, you see that we see a post in profile. So we see a line instead of seeing this en face. So this is the confirmation that we have a good commissural alignment with this device for this patient.
Okay, nice. So let's insert. We may have to correct a little bit, a couple of degrees, the caudal projection, I guess, just to remove some parallax for the stent frame. Okay. And we're going to start quite high for this patient particularly. Let's do an injection here. Okay, perfect. So it's quite unusual that we start exactly in the middle of the anatomy, but it may be useful here in this particular patient. So you're going to start, Nico,
Yeah.
and then we will fast-pace at one point. And we pay a close look to the ECG.
So far it's stable.
So I like the way you go very slowly. Okay, so let's record first here. And the goal is really to aim high. So we may start to fast pace, 120, 120. Okay, I think you can open up a little bit more, Nico. It's really stable, and that's something that I really like from that catheter.
Yeah, and catheter and the valve also with this intra-annular position of the leaflets that makes the valve functions as soon as it flares, and then it participates to the stability. Huh?
Yeah. So we can withdraw the pacing just to see what we have. There was that right bundle branch block, so we have to see if there is something. There is no conduction disturbance at all. You can see that there is still the right bundle branch block. So that position is nice for the patient. Now let's see if it matches the expectations in terms of regurgitation and so on.
Of course.
We still have some parallax, Nico.
Yeah, you want me to correct that?
We can remove that and just analyze the position.
Like that.
Okay, let's inject, Sabine.
So I like it, huh? I like it. The depth is not too important. Almost trivial of a mild leak at the moment, but the valve is not fully deployed, so it's not the final status of the frame. So it's
position looks good. So okay. So let's we may stay in that projection. I'm just going to remove the pigtail.
Okay, I'm pulling a little bit on the stiff wire, centering the nose cone.
And we're going to fast pace, Marlene, at 120 once again.
Yeah. And sorry, we have just to reconnect.
Just reconnect. Okay, good. And you can reopen. I'm just going to control the outflow portion just to avoid a sudden jump, but this is really exceptional with that catheter that is really stable, I have to say.
Okay, good.
We can stop the pacing. Thank you, Marlene.
So we still have maybe one eyelet that is a little bit in contact with the catheter. So
I will let you just play with the wire, maybe, Nico.
Yeah, push-pull.
Yeah, and you see. Okay. Definitely. So that was a nice movement.
Is it okay for you? Do you want me to withdraw the catheter? Yeah.
Thank you, Nico. So let's reinsert the 16 French sheath, do the hemodynamics, and then assess the angio.
So Didier, here are the hemodynamic curves post-implant. So of course, no gradient. LV and diastolic pressure is stable. Aortic diastolic is at 40. So it might be related to a leak, but we see sometimes in such patients also a very important arterial stiffness that explains for this huge pulse arterial pressure. So let's control with angio, and we'll have the solution.
And the heart rate is very stable.
Yeah, it's the same. No heavy block.
Okay. So let me just withdraw the pigtail. So it's and then we came back to our. Let's first record as we are in the cusp of a lab view. First, the angio without contrast.
Yeah.
Okay. And just to once again illustrate what you were saying, Nico.
Exactly. We see if you now look at the right part of the aortic roots, just above calcification that is around the sinotubular junction, left sinotubular junction, you see the posts seen in profile. It appears that there is a small highly radiopaque line. And on the same level, on the left, you see the two of the posts seen en face. So this view is the one you want to achieve when you have a good commissural alignment with this portico device in cusp overlap view, confirming that it was obtained.
So perfect. So let's do the final angiogram before we move to the coronary treatment, because there is still that LAD lesion that requires a treatment. Thank you, Sabine. So the depth is really nice.
Yeah, depth is nice. Mild leak, so it's totally good. and the deployment of the valve is harmonious. It's fine. We see good indirect coronary perfusion. So let's proceed
to the PCI.
To a PCI.
Okay, perfect. Thank you.
So Didier, while you're making your exchanges, maybe a few words about this PCI technique. Across a high frame transcatheter heart valve. So we're going to see that in a few seconds, but mainly what are your main tips and tricks?
So the first idea is to try to cross the device centrally to make sure that we have a wire that gets into the left ventricle. We're going to repeat that. And this is just to make sure that we are not coming from the side and entering the central part of the portico device and then through the leaflets. It's just to be sure that we are central. So the idea is to make sure that you fall into the left ventricle with a wire, and then that wire is going to drag that guiding catheter, and just to make sure that you are central. And that's really the first step. If you can achieve that, it's better.
Idea behind that is just to avoid to cross through a strut of the outflow portion, because you can really easily do that.
Exactly.
And afterwards it will be a physical difficulty to control your guiding catheter and to go where you want to go.
Exactly. So now that we are central, I will try to with the wire now to get access across the struts. We've selected a 3-0 EBU just to match the fact that we are working into a stent frame, and you see that if you have a proper commissural alignment, a nice implant depth, it's very easy to achieve the coronary cannulation to get access to the coronary artery.
Yeah, so you downside your shape by 0.5 approximately. Yeah,
exactly.
Okay, good.
So let's image the lesion, and then we're going to see if... Okay.
A very tight lesion.
Yeah, very tight. So let's treat that lesion, and then we're gonna at the end, I think it will be time to wrap up, Nico.
Yeah.
Treat the lesion, if necessary, reassess the result at the level of the valve after 10 minutes of expansion, and then the closure of the vessel.
Didier, we've just finished the case. You closed the femoral artery. You have under your eyes the iliofemoral angiography. That is good. No residual vascular complication. Maybe we can just come back to the final aortic root angio, confirming our outcome that was good. So depth of implantation that is controlled, not too important. Good commissural alignment, trivial leak, and last information important, the final result after PCI of his LAD diagonal lesion. That went well and without any technical difficulty in this context through the frame. So Didier, if we maybe summarize the key learnings or most important points of this case, I think it was the opportunity for us to review the main contemporary technique and steps of the portico valve implantation, focusing on the cusp overlap technique in order to minimize the AV conduction disturbances, and this patient doesn't have any so far. And on the second aspect, that is a commissural alignment, in order to make the future reaccess to coronary arteries easier. And I think it was good example here regarding the positioning of the valve and regarding the technique to reaccess this left main to perform the LAD diagonal PCI. So I have to thank you, Didier, for this beautiful case. Thanks our team, of course, Sabine, Marlène, who were with us. And thank you for attending this webinar, and hope to see you soon.
Bye-bye.